So, dear friends, colleagues, students, fellows, welcome to this special edition of our webinars on Young India Intensivist Forum. And today we have a very special guest and speaker, an international expert in critical care nephrology, Professor MARLIES OSTERMANN ma'am from UK. So she needs no introduction to all the intensivists. Her work is well known and she has contributed greatly to research in acute kidney injury. And it's a real privilege and honor to have her with us and speaking to us. I hope it will be great learning for everybody. So just to briefly introduce her work to you, she is a consultant in critical care and nephrology at Guy's and St. Thomas NHS Foundation Trust. She is honorary senior lecturer, King's College London. She is professor of intensive care, King's College London. She is chair of research committee, European Society of Intensive Care Medicine. She is director of research, Intensive Care Society, UK. And she has won numerous awards, just to name a few: International Vicenza Award in Critical Care Nephrology 2017, CRN Cardiovascular Research Award UK 2017, and the Sechenov Award from Moscow for 2020, 2020 again FICM and NHR Award, 2021 International Jeff Gray Award, and the testimony to a great work is 475 publications with more than 30,000 citations. Indeed remarkable, and we are really privileged to have you with us, ma'am. So we look forward to your talk.
Thank you very much for this very kind introduction, and also for the honor to present at your esteemed lecture series. I am sorry we can't do this in person, but I always enjoy meeting people from India and going to India to meetings, and I've learned so much from colleagues from India. So it is really a great honor. And what I'm going to present is the work of many people across the world, including major contributions from India. I've been asked to cover pathophysiology and management of acute kidney injury, and also look at different types of acute kidney injury. So I intend to talk for about 35 minutes, and hopefully there will be time for some questions and discussions where we can all learn from each other. So these are my disclosures, and they've not influenced what I'm going to say. Acute kidney injury is a syndrome. It affects more than 1 in 5 patients in hospital and more than 1 in 2 patients in the intensive care unit. And as you all know, it's a syndrome. It has hundreds of different etiologies. It's usually multifactorial, and acute kidney injury in 2 patients is never the same. Here we have the most common causes of acute kidney injury in hospitalized patients, with sepsis, cardiac surgery, and drugs being the main causes. But obviously there's a lot of overlap, and a lot of patients have acute kidney injury from multiple reasons. And this can make it hard to, first of all, identify the main culprit, and may also make it hard to determine the exact management. And finally, this is probably the reason why it's been so difficult to find specific drugs for acute kidney injury. And then not only are the causes different, there are also many other factors that contribute to the heterogeneous picture, because we all practice in different environments and different settings. Patients have different comorbidities that may affect their response to a nephrotoxic trigger. And then lastly, we treat patients sometimes differently. And the way we look after patients, the way we use fluids, mechanical ventilation, inotropes, and so forth, may impact the clinical picture of acute kidney injury and the outcome. So it's a very heterogeneous syndrome. But we do know that the kidneys are very vulnerable. They're very, very vulnerable in an acute illness. And that's for many reasons. Now, the kidneys in health are mainly vascular organs, and they receive, on average, 20% of our cardiac output. And as you can see, within the kidneys, the majority of blood is in the cortex, and less blood is in the medulla. But the structures within the medulla are heavily dependent on blood supply. And as you can see here, in fact, it's a very close relationship between the tubular structures and the blood vessels. The tubules are surrounded by peritubular blood vessels. And this allows this very close relationship, but also allows a very close functional relationship, because the tubules reabsorb more than 99% of the water and the sodium. And to do this, they require delivery of oxygen and metabolic products. And interestingly, the kidneys, and in particular the tubules, are able to do their job. They're able to reabsorb water and sodium and many other substances under hypoxic conditions. So the normal PO2 within the medulla for a working tubule is less than 3 kilopascal, or less than 20 millimeter mercury. But you can imagine that this makes the tubules also very vulnerable if the blood supply to the medulla reduces for different reasons. In health, there's a very tight regulation of the microcirculatory oxygen delivery, and numerous paracrine processes, hormones, and neurosympathetic processes play an important role. But they ensure that the tubules receive enough oxygen and receive enough nutrients and all the relevant factors to do their job, to concentrate the ultrafiltrate. This is what the tubules do. They reabsorb sodium and water, but they obviously rely on adequate glomerular function. And in health, again, glomerular function depends on the relationship between the afferent and the efferent artery. And glomerular filtration is directly related to the pressure gradient, or the pressure difference between these two blood vessels. And again, in health, this is nicely regulated. But when people become ill, then new processes occur, and this regulation is disturbed. For instance, during conditions associated with inflammation or in sepsis, pre-existing shunts form, and they are responsible for a reduction in glomerular filtration, because if you develop shunts, or the vascular tone of the efferent branch is altered, then you can immediately see that glomerular filtration will significantly reduce and may actually stop completely. And if glomerular filtration stops, then there is little to do for the tubular cells. Now, kidney function heavily depends on blood supply and heavily depends on the microcirculation. But there are so many conditions, mainly obviously sepsis, where microcirculation is impacted and reduced, and that's because the vascular tone may be altered, there may be endothelial dysfunction, or there may be the formation of microthrombi disturbing blood flow. And when this happens in a patient, then this clearly affects the kidneys and affects the microcirculation within the kidney, and it affects the function of each individual nephron. There's also some additional tubular injury in many conditions, and that's because obviously the kidneys filter and filter the blood, clean the blood, and produce in health an ultrafiltrate of up to 180 liters. And this ultrafiltrate contains water, but also all metabolic waste products and inflammatory substances. And as you can see here, the tubular cells are at the receiving end of all these potentially toxic substances, but also inflammatory mediators. And so lots of damage-associated molecular patterns and pathogen-associated molecular patterns, which occur in sepsis and inflammation, will be produced, and they get filtered at glomerular level and reach the tubular cells from within the lumen. And they easily bind to tubular cells and can cause damage and reduce the function of the tubular cells. Now this, together with impaired microcirculation as a result of endothelial dysfunction or hypotension, contributes to tubular injury. And you can imagine or easily see that the tubular cells here are damaged from within the tubule and by not receiving adequate oxygen and nutrients. And then lastly, as I've already said, you also obviously may have very reduced glomerular filtration as a result of shunts and changes in the regulation of blood flow. So independent of the cause, the nephrons are at very high risk of being damaged, and particularly the tubular cells. And they're particularly at risk because in health, they only receive or work in an environment with an oxygen level of less than 3 kilopascal or less than 20 millimeter mercury. And this can be easily reduced as a result of these processes. We also know that the kidneys are inflammatory organs themselves. So they are at the receiving end of the blood. The blood may contain inflammatory cells. And so as these inflammatory cells pass through the kidney, other cells get activated and upregulated. And this means that the kidneys themselves contribute to inflammation in inflammatory conditions. And all these processes are displayed here in this cartoon from a paper in the New England Journal of Medicine, where you have a normal, healthy kidney on your left and have a nice differentiation between the tubules and the blood vessels, surrounding blood vessels. You can see they're very closely lined up next to each other. And in any condition that can cause acute kidney injury, you have a disturbance. You have a disturbance of the microcirculation. You have a disturbance of the tubular cells. You may have inflammation and integration, but also activation of new cells between the tubular cells and the blood vessels. And therefore, acute kidney injury itself should be viewed as a pro-inflammatory condition. Furthermore, some of these cells may trigger inflammation themselves and may release various pro-inflammatory cytokines, which then get released into the systemic circulation and may contribute to organ crosstalk, may contribute to the damage of acute kidney injury in other organs. So these are the main reasons why acute kidney injury occurs, but in certain situations and in certain patients, there are additional factors, and they are worth mentioning. We now know that the kidneys themselves don't like to be fluid overloaded. The kidneys, similar to the brain, are surrounded by a tight structure, in this case, in the kidney's case, the tight capsule. So in conditions associated with high renal vein pressure, so that's fluid overload or right-sided heart failure, the pressure within the renal vein goes up, and this can lead to intrarenal congestion, intrarenal compartment, and occlusion and compression of the renal veins, all of which contribute to either new acute kidney injury or progression of acute kidney injury. And it's been argued, but in future we should focus more on the renal perfusion pressure, which is the difference between the mean arterial pressure and the renal vein pressure. But I'll get back to that in a few minutes. And then coming to the end of pathophysiology, it's important to highlight that mitochondrial changes also occur in certain conditions. And we now know that in certain acute conditions like sepsis or inflammation, the mitochondrial energy production is impaired. And in particular, the conversion of pyruvate to acetyl coacetyl. And this is impaired within the tubular cells, who are obviously amongst the most active cells in the body. And this means that the tubular cells, again, are impacted and compromised further in acute conditions. Not only are they compromised by receiving less oxygen and being damaged from within the tubule, within the cells, there are problems in it producing enough energy. We now know that the kidneys, tubular cells, prepare themselves for this, and they can reprioritize the energy consumption and downregulate various processes. Essentially, this is probably the reason for the what we often call ATN, or acute tubular necrosis, where the cells shut down. And whilst this is a protective process, this can, if it lasts long, lead to prolonged tubular damage and actually tubular cell death. And then finally, obviously, in certain conditions, there may also be additional pathophysiological processes. So we may have patients who have additional risk factors and contributed to acute kidney injury. Patients may receive drugs that are particularly tubular toxic. They may be directly tubular toxic, or they may cause tubular damage as a result of intratubular obstruction, like acyclovir crystals, for instance. And all the things which I talked about are obviously worse and more impactful in patients who already have reduced renal reserve and reduced nephron mass, as, for instance, patients with chronic kidney disease. So in the acute setting, in patients in the intensive care unit, the kidneys are extremely vulnerable, and they react to nephrotoxic triggers in numerous ways. And here we have a summary of these various pathological processes that I talked about. And in a lot of patients, they all happen at the same time, or they happen one after the other. But this is what makes it so, can make it difficult to understand why acute kidney injury has occurred. And it has led to the challenge of finding specific therapies for acute kidney injury. Now, when it comes to management of acute kidney injury, again, I want to show you this picture again and highlight that there's so many causes of acute kidney injury, and that's why it may be difficult to find the specific cause. The most important cause, management step is obviously to try and treat the underlying problem. But otherwise, management is very generic at the moment and very general. And here we have the treatment bundle, the recommended treatment bundle from the KDIGO guideline from 2012. And although it's now 10 years old, more than 10 years actually, it is still valid. We still don't have a specific treatment for acute kidney injury. It's reminds us to essentially get the basics right and focus on hemodynamic and fluid optimization. What's not listed in this bundle is to treat the underlying etiology, and that's even more important than fluid and hemodynamic management. So assuming that patients have their underlying etiology, whether it's sepsis or hypotension or drug toxicity, corrected, then we're encouraged to optimize everything and spend time correcting and focusing on details, getting the basics right. And clearly this makes sense. It makes sense to discontinue all nephrotoxic agents where possible. We have to acknowledge that may not always be possible, because some patients may well need nephrotoxic antibiotics. But where possible, they should be discontinued. Now, the next recommendation makes sense. It makes sense to say patients, to ensure that patients have an adequate volume status and perfusion pressure. But when you try to incorporate this into clinical practice, it's actually much harder. And it's harder because we have no tools to measure intrarenal hemodynamics. What we do have, we can measure the systemic blood pressure, we can assess the macrocirculation. But I've highlighted the importance of the microcirculation, and I've highlighted the disturbed glomerular pressures and alteration in glomerular hemodynamics in sepsis, for instance, or in acute illnesses. But at the moment, we have no tools to look at intrarenal hemodynamics. And we assume that an adequate blood pressure will then also translate into adequate microcirculation and adequate glomerular perfusion. And there are many assumptions, and this may not always be correct. But that's a challenge in clinical practice. Now, kidneys are vulnerable. We don't know the optimal blood pressure to keep them functioning. But what we do know is that kidneys don't like hypotension. And there are several studies, but I just picked one here, which is a systematic review of 42 studies in the literature. And they looked at the impact of documented hypotension during surgery, doing any form of surgery. And as you can see here, if you look at hypotension on the left-hand side, and you look at different degrees of hypotension or different durations, then you will see that the lower the blood pressure and the longer the duration, the higher the risk of harm. And the kidneys appear particularly vulnerable. So hypotension, as defined by a blood pressure of less than 60 for just a few minutes, was independently associated with an increased risk of acute kidney injury after surgery. And the kidneys seem to be more vulnerable than, for instance, the brain. So we don't know the optimal blood pressure, but we do know that patients don't like, or kidneys don't like hypotension. So would it help to keep the blood pressure higher? Well, we haven't done this study. There's no randomized controlled trial looking at different blood pressure targets in patients to prevent acute kidney injury, but we have some indirect evidence, and certainly evidence from the study by Asfa and colleagues in France. And in this study, they obviously looked at blood pressure targets in patients with septic shock, comparing 65 to 70 with 80 to 85 millimeter mercury as a target. Now, in this study, there was no difference in mortality. And there was no difference in overall AKI. But in a subgroup of patients with pre-existing chronic hypertension, this group benefited from being randomized to the higher blood pressure target, and less patients needed renal replacement therapy. And again, it reminds us that patients are different and that patients may well need different blood pressure targets, and that we in future need to study this in more detail. It may also mean that the blood pressure, the mean arterial blood pressure, may not be the most important target, and maybe in future we need to focus more on the renal perfusion pressure. Because as you can clearly see here, if the CVP or the renal vein pressure is high, then different mean arterial blood pressures will have a different effect. And there is a call now and a suggestion that to prevent acute kidney injury and to treat acute kidney injury, it may be better in future to look at renal perfusion pressure, which in healthy people is around 60. So the current KDIGO guideline, which was published in 2012, acknowledges that we don't know the optimal blood pressure and we don't know the optimal vasopressor for patients who are at risk of hypotension. It is hoped that the updated guideline, which is in process at the moment, will be published in 2025, will give more detailed recommendations. So in 2012, it was recommended that that noradrenaline or norepinephrine was the most commonly used medication to correct hypotension, and there was no evidence that any other vasopressor was better. But we do know now that different vasopressors have a different effect on the kidneys. And that is important because if we acknowledge that that hypotension is bad and we want to correct it, then we ideally want to correct hypotension with the most effective vasoconstrictor. And as you can see from the slide, again, that different vasoconstrictors act on different branches of the glomerulus. And this may have a complete opposite effect when it comes to glomerular filtration. So constricting the afferent branch has a different effect than vasoconstriction of the efferent branch. And this is very important because we know that different vasoconstrictors, as they are available in the literature and in clinical practice, act differently. And it may be that we've not seen results from these blood pressure trials because clinicians use different vasopressors and more focus on these specific vasopressors in the setting of acute kidney injury may be necessary in future. Now, finally, I also like to briefly mention fluids because fluids are obviously an integral component of acute kidney injury management. And here we have the most commonly used fluids across the world. Not all of them will be available everywhere, but most countries have saline available and most countries have some form of buffered fluids, but not all of them will be available everywhere. But what they clearly show is that any type of fluid is an artificial fluid because they're all different from plasma. And some are more different and others are have less differences. And for a long time, and still ongoing, we've debated whether saline is potentially harmful to kidney function or not. And the concern stems from the fact that saline has high chloride concentration, an unphysiologic chloride concentration. And it is known that chloride is harmful to glomerular function because a raised chloride level in the blood will act as a vasoconstrictor of the afferent branch. And as you can see and imagine, this will reduce glomerular filtration. So the question is whether it is safe and advisable to give saline to people who are at risk of acute kidney injury or have acute kidney injury. And this question has been discussed now and debated for more than 10 years. We have some evidence from the literature, and I'll just review the most recent studies briefly. But certainly the SMART trial conducted in the US suggested that buffered solutions were better. So this was a single-centered study in a university hospital with 5 different intensive care units. And patients who went to the intensive care unit received either saline or a balanced solution, depending on which ICU they were admitted to. So the ICUs were randomized. And then they received one type of fluid from the beginning until the end. And the trial looked at MAKE 30 as an outcome, so major adverse kidney events. And when looking at this outcome, which is a composite outcome, there was a significant difference between the two groups. So patients who were admitted to an intensive care unit that had been randomized to a balanced solution had a significantly lower risk of a MAKE 30 event. But MAKE-30 is a composite outcome. And if you look at the components of MAKE-30, which is mortality, new renal replacement therapy within 30 days, and a final creatinine, which was more than 200% greater than baseline, you will see that there was a trend towards better outcomes in the buffered fluid group, but it didn't reach statistical significance. But as a composite, there was a significant difference, suggesting that buffered solution or balanced solutions were better for kidneys and kidney outcomes. Now, subsequently, 2 large trials were conducted, and they were unable to confirm these results. So we had the BASICS trial conducted in Brazil in 75 ICUs, which was double-blinded, and in this case, patients were randomized. And again, they received either a balanced solution or saline. And in this trial, there was no difference in 90-day mortality. And there was also no difference in any of the renal outcomes. And they looked at acute kidney injury in different forms. So either at different days or in combination with mortality. And as shown in this table, there was no real difference between the patients who had received saline versus balanced solutions in this double-blind randomized control trial. Whilst the BASICS trial was going on in South America, colleagues in New Zealand and Australia conducted the PLUS trial, again with the same question. Again, a double-blind randomized control trial where patients were randomized to either a balanced solution versus saline. And again, they would receive the type of fluid from the beginning until the end of fluid therapy. They looked at 90-day mortality and renal outcomes. And again, with regards to 90-day mortality, there was no difference between the 2 groups. There was also no difference in outcome between when they looked at different subgroups. It appeared that balanced solutions may be better, as you can see right at the bottom of this forest plot, but the difference did not reach statistical significance. And when they looked at renal outcomes, and that's the lines here, the rows here in the middle of this figure, there was no difference in newly initiated renal replacement therapy and no difference in the maximum creatinine between the 2 groups. And so this study, like the BASIC trial, concluded that the use of balanced solutions did not result in a lower risk of acute kidney injury compared to saline. So this left a lot of people, including myself, very confused because we had these data, some suggesting that buffered solutions were better, some suggesting that saline was harmful to kidney function. And then in 2 double-blind randomized controlled trials, there was no difference. So the investigators of the PLUS trial very quickly got together with the authors of all the other papers and produced an updated meta-analysis, which included the data of all randomized controlled trials, including PLUS and BASICS. And they meta-analyzed the data of more than 35,000 patients. So to date, the largest meta-analysis. And they focused on mortality and acute kidney injury. And if you look at mortality, look at the outcome of these 35,000 patients, then the risk of death is higher in patients who'd had saline. So the estimated effect of a balanced crystalloid versus saline ranges from a 9% relative reduction to a possible 1% relative increase in the risk of death. And they found the same when they looked at acute kidney injury. So the effect of using a balanced crystalloid results in a possible up to a 9% relative reduction of the risk of acute kidney injury, but up to a possible 1% relative increase. So the pendulum swings in favor of balanced solutions, but it's statistically not significant. And this is where we are at the moment. We are, when it comes to fluids, we're at a point where we all understand that euvolemia is probably the best state, where we know that hypovolemia is harmful, but we also have increasing evidence that hypervolemia leads to renal congestion and needs to be corrected. And with regards to the type of fluid to correct hypovolemia, it appears that buffered solutions are recommended, but there is some overlap with saline, and the data don't show 100% convincing, statistically important differences. So this is where we are. We manage acute kidney injury by following the KDIGO recommendations, focusing on hemodynamic and fluid optimization, and treating the underlying cause, correcting the underlying cause. To date, we do not have any specific drugs for acute kidney injury. And this is most likely the result of our difficulty in identifying the exact cause of the exact pathophysiology of acute kidney injury in individual patients. There are hundreds of causes of acute kidney injury and so many different underlying pathophysiological processes. And it is unlikely that a drug or an intervention that addresses one intervention can then prevent acute kidney injury in everybody. And we have very promising drugs that are currently under investigation that may address either glomerular hemodynamics, glomerular regulation. There are drugs that help tubular cells recovering. There are drugs that help tubular cells being less vulnerable. There are drugs available that help and protect mitochondrial function in tubular cells. And then obviously we have various drugs that may reduce the inflammation within kidneys. But some of them are still under investigation. But the challenge is for us to identify the patients, the subtypes who have acute kidney injury from one reason, for one cause, or with a particular underlying pathophysiology, so that we can study these drugs in individual subtypes. So in conclusion, I fully understand that we haven't moved forward a lot in the way we manage acute kidney injury, but we certainly have a much better understanding, and we now are much more aware of the different underlying pathophysiological processes that can occur in acute kidney injury. Our strategies are unchanged. They are still the same as in 2012 when the KDIGO guideline was published, recommending optimization of fluid and hemodynamic status. But we are seeking better ways to identify subphenotypes from different causes of acute kidney injury or subphenotypes with particular pathophysiological processes, and that we can then test these new drugs and interventions in these particular subgroups. And I think that's probably the way forward to make a difference in the management of acute kidney injury. Thank you for your attention.
Thank you, Professor Ostermann, ma'am, for the wonderful talk. A lot of information and a lot of understanding we have gained from that. Just while we wait for questions from the audience, audience is requested to type in their questions. I would like to just, ma'am, ask a few questions for everybody's sake and for myself. So you showed the last slide on drugs, ma'am, drug therapy, potential drug therapy. One of the exciting drugs is recombinant human alkaline phosphatase. Would you like to talk about that, ma'am?
Sure. Let me just get back to that. Can you still see it?
Slide has gone, ma'am. Slide can't be seen.
Okay.
Yeah,
can you see it again? Yeah, so alkaline phosphatase is mentioned at the bottom here. So alkaline phosphatase is very exciting because it's it's a medication that has been tested, or is a substance that has been tested in patients with sepsis-associated acute kidney injury, and that's obviously sepsis-associated acute kidney injury is amongst the top causes of acute kidney injury. And we've now had at least several trials, but the most recent trial was the Revival trial published in the in intensive care medicine this month. And the alkaline phosphatase was first studied in the STOP-AKI trial, where patients with sepsis-associated acute kidney injury were given alkaline phosphatase with the intention that alkaline phosphatase would help tubular cells recovering faster. And that's essentially the intention of alkaline phosphatase, helping damaged, injured cells to recover faster. And in the STOP-AKI trial, published a few years ago, there was no difference in the primary outcome, which was kidney function at 7 days. So the primary outcome was no different, and therefore you could say it was a negative trial. But there was better kidney function at 28 days in the treatment group. So longer, beyond 7 days, patients who had received alkaline phosphatase in the context of sepsis-associated AKI had better kidney function at 28 days, and there was also a mortality difference. It was much lower mortality. So this led to the Revival study, which looked at alkaline phosphatase again in patients with sepsis-associated acute kidney injury. And in the Revival study, the primary outcome was mortality. The trial got terminated halfway after an interim analysis showed no difference in mortality. The results are published in Intensive Care Medicine this month. And although there was no difference in mortality in the Revival trial, again, there was much better kidney signal in the patients who had received alkaline phosphatase. So we haven't got the answer yet, but the 2 large randomized controlled trials all suggest that alkaline phosphatase is a very promising drug for patients with acute kidney injury. And it appears to protect kidney function and allow earlier recovery. We just need to look at this again in a different way and trial. But the data so far support the protective effect.
Right, ma'am. Thank you. So, ma'am, moving on to pre-renal AKI. Ma'am, can you stop the share screen, please? I don't think we'll need the slide.
Sure.
Ma'am, so moving on to pre-renal acute kidney injury and ischemic ATN. So pre-renal AKI is always oliguric, right, ma'am? And most of the times we end up giving fluids for pre-renal AKI, and sometimes pre-renal AKI goes on to ischemic ATN. So pre-renal AKI is oliguric, and then you have acute tubular necrosis, sometimes developing from pre-renal AKI. So generally that is also oliguric, if you get ischemic ATN. But does it happen that ischemic ATN converting from pre-renal AKI can be non-oliguric?
So at the moment, a lot of textbooks still talk about pre-renal, renal, and post-renal AKI, but there's a large body of opinion and valid opinion saying that we should move away from this and that what we determine pre-renal, which is traditionally in the textbooks is renal for acute kidney injury as a result of hypovolemia or hypotension, is actually much more harmful than we thought. There's clear evidence from the literature that acute kidney injury as a result of hypovolemia or hypotension does not necessarily always need fluid, that it is associated with quite severe tubular injury. And the body of opinion and supported by evidence is concerned that pre-renal automatically gets translated into hypovolemic acute kidney injury, because and that patients then invariably get fluid and potentially get overloaded. And instead, people are moving now towards a classification where we try to find the underlying etiology and describe, for instance, and talk more about functional acute kidney injury, damage-associated acute kidney injury, significant, severe, or moderate acute kidney injury, rather than using a term that may potentially trigger a reaction. And I'm saying this, so pre-renal, what used to be pre-renal acute kidney injury, may be oliguric, but patients may be oliguric even in the context of being fluid overloaded. So if you think of the congested kidney in patients with right-sided heart failure or fluid overload, these patients are oliguric, and still within the kidneys they are congested and dry, and there may be intrarenal compartment.
Right now. So just taking that forward, non-oliguric and oliguric AKI, the prognosis for non-oliguric AKI is better than oliguric. Am I right, ma'am? Generally.
That is correct.
So,
that is correct.
So what is the physiological difference between the two, ma'am, non-oliguric and oliguric? How do we understand this? The prognosis is better, and what is the physiological difference?
So in oliguric, so in non-oliguric AKI, there will still be some glomerular function, because clearly you need to make a glomerular filtrate to produce urine output. And the tubular cells may be damaged and they may be unable to reabsorb water and sodium. But there is at least some glomerular filtration. And in oliguric acute kidney injury, glomerular filtration may be reduced and tubular function may also be reduced, but a glomerular filtration will be significantly reduced. And that's a result. So that's an impairment of function, and impairment of function occurs after the original damage has occurred. So it's within the pathophysiology is a much further phase, much further down the line.
Thank you, ma'am. So, ma'am, moving on to the use of vasopressors. Now, you showed one slide, and there is no data to suggest norepinephrine, vasopressin over norepinephrine as far as the current literature goes. They say use norepinephrine in septic shock with AKI. But there is data to suggest vasopressin has a renal protective effect in sepsis. There is some data. So if there was septic shock with kidney injury and you have to use a single vasopressor, should we go for vasopressin? Or rather not,
Well, the data to support vasopressin is is limited. There's also data showing that angiotensin in this scenario may restore glomerular filtration, because it acts predominantly on the efferent branch of the glomerular blood vessels. And the sub-analysis of the Athos trial showed that patients who were randomized to angiotensin 2 came off renal replacement therapy much faster. And this is consistent with the physiology, so that angiotensin is a vasoconstrictor of the efferent branch and increases the gradient and increases the filtration pressure at glomerular level. But all of these data, the vasopressin data, the angiotensin data, are at the moment preliminary and have to be repeated and tested again, and in adequately powered randomized controlled trials. So all we have at the moment is data, indirect data from larger studies.
Thank you, ma'am. So just another question on vasopressin. So vasopressin is supposed to cause hyponatremia, ma'am. it's an antidiuretic hormone, and it's used in high levels. Serum levels are pretty high when you use it in septic shock as a vasoconstrictor. But the incidence of hyponatremia is very low. You hardly see hyponatremia. So why is that so, man?
I think so in this setting, when we use vasopressin in patients with septic shock, there's such disturbance of the normal endocrine hormonal regulation that the hyponatremic effect is negligible, because there are so many other things going on, plus so many processes are altered and dysregulated.
Right, thank you, ma'am. So just a last question, ma'am, before we close it. Your opinion on where we are with biomarkers and how we should be using them, ma'am.
So biomarker is anything that gives us additional information about the underlying etiology or pathophysiological processes. So we already use creatinine and urine output as our current biomarkers. We also have traditional other biomarkers like urine protein, urinalysis. We don't use them very often, in fairness, in the intensive care unit, but they are available to us. An ultrasound is a biomarker. It gives us additional imaging of the kidneys. They are not routinely used, and they're not used in a structured manner in most intensive care units, but they could give us more information than we currently have, because ultimately what we need to do to move forward is identify the exact subphenotype of acute kidney injury, if possible, identify the cause of acute kidney injury so that we can address it, and then also address the underlying pathophysiology. But the key question is whether new novel biomarkers can give us additional information. So novel biomarkers, either functional biomarkers like cystatin C or proenkephalin, which is available, or new damage biomarkers like NGAL or the cell cycle arrest markers. What we do know is if we measure all of them, then we get a much better granular picture of acute kidney injury, and we can, for instance, find out where the most likely anatomical site of injury is. Some of these biomarkers also give us information about prognosis and prediction. And some of them undoubtedly diagnose acute kidney injury before the creatinine goes up. None of us can afford to use all of these biomarkers. That's unaffordable at the moment in any health setting. But could we use some of these biomarkers in particular patient populations to either diagnose acute kidney injury earlier or identify those who are at highest risk? I think that's possible. We have a few trials and studies showing that measurement of biomarkers can detect early acute kidney injury in particular patient groups earlier, for instance, patients after cardiac surgery. And this may enable us to start the optimization process further. We have data from some institutions showing that the use of biomarkers allowed them to differentiate between drug-induced acute kidney injury versus hemodynamic acute kidney injury. And this allowed them to make a decision whether to stop nephrotoxic drugs or not. So in conclusion, I believe these novel additional biomarkers have a role. They give us extra granularity, but we need to use them wisely, and we need to, and at the moment, we can only use them in particular patient groups where we can then act on the information and change what we do. But much more work is necessary before we can routinely implement them across the world in every institution.
Thank you so much. So I think there are no more questions. Thank you very much, Professor Ostermann, ma'am. It was wonderful, and it was indeed a pleasure and honor to have you with us. Thank you very much, ma'am.
It's also an honor on my side. Thank you.
Thank you, ma'am.